Now let's talk about how the electrolyte changes in diuretics. So urine, sodium, and chloride. In urine, you have the sodium chloride. It increases with all diuretics. So sodium and chloride will in urine would be seen with all diuretics, but the concentration varies depending on the potency of diuretic effect. Serum sodium chloride may decrease as a result, depending upon the potency of the diuretic. Urine potassium increases, especially with loop and thiazide diuretic, excluding the potassium sparing diuretic, which is sparing the potassium itself. Blood pH. Now, blood pH, acidemia would be caused by carbonic anhydrase inhibitors. We talked about it already, because it decreases the bicarb reabsorption, and bicarb is it's a base or basic. When you cannot reabsorb a base, you're gonna go into acid, leading to acidemia. And potassium sparing aldosterone blockade prevents the potassium secretion and hydrogen secretion. Okay. Additionally, hyperkalemia leads to potassium entering all cells via hydrogen potassium exchanger in exchange for hydrogen in exiting cells. So that's all for the acidemia. Alkalemia can be caused by loops and thiazides. So again, let me do this. Acidemia was caused by carbonic anhydrase inhibitors and potassium sparings, while alkalemia is caused by loop diuretics and thiazides through several mechanisms. What are the mechanisms? We have the volume contraction, which when you have a volume contraction, it causes increase in angiotensin, aldosterone, and causes increase in angiotensin too, which leads to increase in sodium potassium exchange in the PCT, leads to bicarb reabsorption and contraction alkalosis. Again, look, there is a reabsorption of bicarb which causes alkalosis, and here you have this decrease in reabsorption which causes acidosis. Then you have the potassium loss, leads to potassium exiting all cells via hydrogen potassium exchanger in exchange for hydrogen entering cells. In low potassium states, hydrogen rather than potassium is exchanged for sodium in the collecting tubules, leads to alkalosis and paradoxical aciduria. Urine calcium increases with loop diuretic, decrease in paracellular calcium reabsorption, leads to hypocalcemia, and decreases with thiazides. Very important. So in with the loops, you're increasing the urine calcium, and that's you already know the mechanism, because you're not getting that positive potential. That's why you're losing the calcium. With thiazide, you're decreasing the calcium, because it enhances the calcium reabsorption. Okay, so that's a differentiating feature between loops and thiazides. And that's the calcium. So that's all for the electrolyte changes in all of the diuretics.